of is that all dementia isn't necessarily something that you inherit or that you have no control over. There are a number of things that you can do to protect your brain and to keep it as healthy as you can, despite any risk factors you might have. And one of those things, and which is why we have Mr. John Lewis start us off all the time, is to exercise on a regular basis. You know, if you want to age healthfully, we advocate very strongly that you get at least 150 minutes of cardiovascular exercise and cardio in a week. Now, you can do it the way John does it. You can do it by walking every day, taking your dog for a walk. You can swim, you can run, you can cycle, you can dance. But as long as you're getting in 150 minutes of vigorous exercise that kind of gets your heartbeat up, that's one of the things that you can do to protect your brain. Protecting your brain is not only keeping your body physically healthy, it's managing things like chronic hypertension and diabetes. And we do that also with diet and exercise. You're going to hear a little bit more about other things that you can do that help protect your brain by making your body a little bit more healthy. We've talked in the past about what should you eat to keep your brain healthy, and that's a Mediterranean diet, basically a low-fat, low-cholesterol diet. Anything that's good for your heart is good for your brain. We want you to stay socially engaged, prevent social isolation, because staying engaged, staying socially active is one of the things that helps keep your brain working and functioning. Aside from these sorts of things, there's managing and getting screened for depression. A lot of people who have problems with memory loss have problems with an affective disorder. Depression is one of the main ones. And a lot of times we don't realize we're suffering from depression, but the good thing about depression is that once we treat it, some of the symptoms, some of the brain fog, some of the sleepiness and fatigue that we experience has a tendency to go away. So we know that when it comes to Alzheimer's disease, main risk factors are advanced age, but also your genetics and also your gender. So being female, being significantly over the age of 65, puts you at risk for having Alzheimer's. But there are other dementias, and we've talked about them on previous sessions. And our objective here is to make you understand, or help you understand, that there is a connection between poor physical health and poor brain health. So what other things can you do besides exercise, besides managing your chronic diseases and screening for and treating depression and managing social isolation? You can get your hearing checked. You can get a sleep test, particularly if you're having difficulty with it, because those are also things that help contribute to brain dysfunction. So we have a couple of presenters here today that are going to talk to you a little bit more about what we can do to stay healthy. I'm going to open this up by introducing Dr. Whitney Wharton, who's in our School of Nursing. She's done a lot of studies on exercise, on gender, and also race as it relates to Alzheimer's disease caregivers. She's also done a lot of research on women and the protective role of estrogen in terms of brain dysfunction. So at this time, I'd like you to reintroduce to some of you Dr. Whitney Wharton, who is the co-director of our Outreach, Recruitment, and Education Core for the Goizueta Alzheimer's Disease Research Center. Whitney.
Hello, everyone. Thank you so much, Dr. Parker, and thank you everyone who's tuning in today. I think right now we have 193 people tuned in, so I see some familiar faces or I should say rather names on the chat, and so much appreciated, and welcome to all of you that are new. So as Dr. Parker mentioned, my name is Dr. Whitney Wharton, and I'm a cognitive neuroscientist and associate professor here at Emory University. And my research deals with Alzheimer's disease prevention and health disparities. And I wanted to share with you all a study that we are just starting. We're in the first couple of months of a very exciting new research study. And what I would like to do is ask all of you to participate in that study. As Dr. Parker mentioned, I'm particularly interested in risk factors that contribute to Alzheimer's, but in all of my studies, I tend to enroll individuals who are at risk but don't yet have Alzheimer's disease. So for this particular study, which is called E2, the E2 study, we are looking for men and women who are 40 years of age and older and either are cognitively normal or just experiencing some mild memory complications, which all of us tend to have as we age. So predominantly cognitively normal. And the main question that we're trying to answer is, why are women more at risk for Alzheimer's disease than men? And we're asking that in a very systematic way. So again, the study is open to both men and women, but what we are going to do is look at Alzheimer's biomarkers in the brain and in the blood, and look at cognitive testing and other markers that seem to be most affected in women compared to men, and then see if there's a difference over a 2-year period of time and see what that change is. The study involves 3 to 5 study visits over a 2-year period. So we see you at baseline, year 1 and year 2. We are very flexible. We work with your schedule. The study visits last probably around 5 hours, and you can split that into 2 days or just keep it at 1 day. The study visits involve MRI scans, blood draw, a vascular ultrasound, because as we heard in what we know from these BrainTalk Lives, what is good for the heart is good for the brain. So you have a non-invasive ultrasound to give us an indicator of your heart health. We also will send you home with an overnight sleep monitor, which is the equivalent of an in-lab sleep study. So it's a really fancy new piece of equipment. So it's a headband with 3 sensors on it, and it takes your pulse, it takes measurements of brain waves, all kinds of fun things as you sleep, so that I know your overall sleep profile or how restorative your sleep actually is. Because especially for women, we know that as we age and as we go through the menopausal transition, oftentimes sleep becomes problematic. So that is one thing that we're going to be measuring over the 2-year period. We also have memory tests and questionnaires. And then we also have a lumbar puncture, which I know we've heard a lot about in these BrainTalk Lives. If any of you have questions or trepidation about the lumbar puncture, I would love to have that conversation with you. The phone number to call for this, you'll speak directly to a member of my team, and her name is Whitney Jacobs. The phone number to contact Winnie, and I'll put this in the chat also, is 404-712-9823. And again, Winnie's phone number is 404-712-9823. Also, I'd just like to mention very quickly that we have a number of studies that are currently recruiting for people who are cognitively normal but might be concerned about their memory, and also people that have a family history of Alzheimer's disease, which is also a risk factor because of genetics and as of yet unknown etiology. So if you would just like to learn anything more about some Alzheimer's disease prevention studies, please give us a call, and I will be around to answer any questions that any of you might have in the chat. Thank you so much.
Okay, Dr. Wharton, you've got to alleviate this trepidation with the lumbar puncture. What can someone expect with the lumbar puncture when they arrive? Like, can we give them the elevator pitch?
Sure, absolutely. So a lumbar puncture, while a lot of people aren't familiar with it, it's actually a very routine research procedure. We have nurse practitioners and physicians who perform about 6 to 8 per day. I personally have 2 staff physicians that perform all of the lumbar punctures for us. The whole thing takes about 40 minutes from the time you walk into the room till having the procedure done, and then we have you lay down for about 20 minutes afterwards just to make sure you feel okay. Just like after you give blood, you want to sit down for at least 5 minutes, which we also have you do after the blood draw. But what happens is we take a very, very thin needle, which is so thin that you can actually bend it into a circle. And we insert the needle into the very small, the very lower part of your back, much farther down than your spinal cord. There's zero risk of paralysis, anything like that. This is also not a spinal tap, and it is not an epidural. So all we're doing is removing some fluid as opposed to inserting any type of liquid. So what we do is take out about 20 cc's, which is about two small tubes of spinal fluid, and it regenerates within 4 hours. And, we also understand that this is a big ask. This is a big thing to ask of participants, especially if you're not familiar with lumbar punctures. The importance of this is that this is the very best way for us to be able to measure the proteins and the enzymes that are in the brain without actually going into the brain. So what we're doing is permeating the sac that encases your spinal cord in your brain. So we don't want to go anywhere near your brain because that might be dangerous. So we are going very far away, but still looking at that same fluid that bathes the brain. And by looking in that fluid, we're able to tell what's really going on. So that is what a lumbar puncture is. The biggest risk factor for a lumbar puncture is a headache. So we just ask participants to, if they have a headache, it's mainly postural. So if you lie down, if you experience a headache the next day, then the headache normally goes away. Avoid bending, lifting, or stretching. But other than that, that is one part of a 5-hour study visit that we do. And the most common comment that I have is, Dr. Wharton, I was nervous about the lumbar puncture, and I now know that it's not as big of a deal as I was thinking about at all. And you walked me through it, but that cognitive testing, I don't want to do the cognitive testing again because that's really hard. I would rather have 3 more lumbar punctures than have 1 more hour of that cognitive testing. So that's a pretty standard response after the 5-hour study visit. So the one other thing I should say is that the study does, that I mentioned, the E2 study does reimburse participants for $300 to a lot of our participants are, because they're cognitively normal, are still working, have to take off time off work and have transportation costs. So we try to compensate you for that. So thank you.
Thank you, Dr. Wharton. I will let you address several of those chats directly. We are going to turn it over to Dr. Allison Lindauer. She's going to be sharing information about a new opportunity. When we launch the poll before every program, thank you all for participating, but we say, how would you describe yourself? And do you know that almost 30% of the viewers state that they are a caregiver of someone with dementia? So I want you to go grab your pen and paper really quick while Dr. Lindauer, we get your PowerPoint up. And this may be an opportunity for you to participate in this research study. Hello, Dr. Lindauer.
Hi, can you hear me okay?
And just give me a second. Did you hear me? Okay.
Yeah.
Okay, go right ahead.
Great. Is my, can you hear me all right?
Yes, give me
Good.
one,
Okay, great.
give me about
Thanks.
30 seconds to get your PowerPoint up.
Oh, no, I can do it from my end if that's
Oh,
all right
good.
with you.
Okay.
Yeah,
I'm
yeah, I
going to
can
make you a
take care of that.
co-host then.
Okay, thank you. Hi, everybody. I'm actually returning your team, Dr. Parker and Cornelya, graciously invited me to present again today. I met with your team earlier this summer to talk about our caregiving research, and I'm really honored to be back and chatting with you again. I'm particularly happy to be here today because in my study, One of the co-investigators, Dr. Wharton, who you just heard, is here as well. So if you have questions for either of us, we'd be happy to share. And I thought what I might do today is talk a little bit more about the study, but also just give you a little update about how we're doing. And I'm happy to entertain your questions. And I'm ready to share whenever you are. Cornelia, it just says I'm not ready.
Okay, keep talking because we are having.
Okay, that's great. I'll just keep talking. So the
Yes.
study is called Stella. And Stella, in Stella, what we do is we work with family members who are trying to understand and deal with the behaviors that come with advancing dementia. And the reality is all of us have behaviors, right? We feel anxious, we feel worried. Oh, thank you. And people with dementia do too. So the point of Stella is to help all of us learn together how to deal with these challenging behaviors and how to really grow together.
And I apologize, Dr. Lindauer, you will have to prompt me to advance your slides because
no
something is wrong.
That's okay. That's fine.
Okay.
That's fine with me. One less thing I have to worry about. So.
Okay.
So just a little bit of background. I'm an associate professor at Oregon Health and Science University, and you're probably wondering, why is Oregon here today? For a couple of reasons. Like your Goizetta Center, we are an Alzheimer's disease research center funded by the NIA. And I know Dr. Wharton and the team from various meetings we've attended. And when I needed to branch out on this study and recruit people from across the US, I was very eager to include this team on my study. So we're recruiting people from Oregon, Georgia, and Kentucky, 3 of the NIH-funded ADRCs. There are 31 of them, but we're just kind of starting small here. So I'm also a nurse practitioner. I specialize in taking care of folks with dementia and their families. And I've noticed over the many years of doing this work that caring for somebody who has dementia is hard on a person, it's hard on a family, both physically, cognitively, and emotionally. And so that's why I developed this intervention. Next slide, please. The good news is that we are going strong. And I'm just going to take just a quick second and talk about who you are as caregivers. A lot of folks, over 20 million, provide care for somebody living with dementia in the US. I'm not going to go through each bullet on this, but the bottom bullet is really what motivates me to do my work. Almost 30% of those who provide care feel alone. So even though they live with the person, they still feel alone or isolated. Next slide. And so the idea is not only are we dealing with some of the behaviors that both everybody in the family is experiencing, we're also introducing you to other caregivers. Next slide. And why don't you keep forwarding a little bit? I know that many of you have seen this slide set, so I don't want to bore you with the repetition. Another slide, please. There we go. So again, our slide is really to help figure out effective ways to deal with some of the symptoms that come with later stage disease. I have professional guides, nurses, neuropsychologists who meet one-to-one. And think the next slide, please, Cornelia. Let's go, there's a graphic. That's where I'm trying to get. Oh, sorry, there. So you meet one-to-one with a guide for 4 weeks, for an hour a week. And these guys really have a lot of experience working with families living with dementia. You tell us where you want to take the conversation, what kind of issues you want to work on, and our guide will work with you through our protocol. After 4 sessions, you meet with 3 to 4 other care partners who are caring for somebody with dementia, just a small group. We just would like you to get a chance to get to know each other so you can be there and you actually have somebody that you can relate to, that you don't have to explain your story to every single time. Next slide. And then later on, about several times a year, we have what's called a constellation where you can meet with a whole bunch of people. There's about anywhere from 10 to 20 care partners, same program, same idea, just more people to help support you. The next slide, please. 8 sessions, about an hour each. And then there's the 8 following the large group. We have you do surveys. And like Whitney said, we understand that for some people, this means having to hire another caregiver or find other ways to free up that hour. So we make sure that we reimburse care partners for their time. Next slide, please. And what's unique about this study is it's all done by video conferencing, just like you're doing here and now. We're not new to the scene. We've been doing this for about 5 years. We know that not everybody has the perfect computer or great internet access. So if you need a computer, we loan computers to you anywhere in the country. And we do provide you with internet service should you need it. And we make sure that you have that tech support that's so critical to making things work. Next slide. And this is our team. These are your guides. And I'm just really excited that this study is going strong. You know, the pandemic has been really tough. We've all felt isolated. It's frustrating to have to deal with yet another wave. This study is safe because it's from the comfort of your own home. You don't travel anywhere. You just meet up with our team on video conferencing. And people are liking the intervention. They're enjoying that. The people that are involved are enjoying the time. So generally, it's a fun way to kind of get to the root of your issues, but also meet others. And like Dr. Parker had said earlier on, it's a way to connect with other caregivers. That's really important when you're doing this kind of work, to be around others and share your experiences. I'm sure you have questions. I'd be happy to entertain. So why don't we close the, oh, I'm sorry, one more slide. How to reach us. I believe the last slide, yes, we do need you. We need family members who care for somebody with dementia. We really need people from Georgia, and we'd love to have you. And I believe the last slide has there's a slide with our contact info. I'm sure they're going to share the slide set with you, but on the very last slide is also Winnie's phone number. We have a Georgia team that's helping us. And so if you have questions, you can contact Winnie and she'll get you to the right people to explain more. And Cornelya, I think, is there one more slide with Winnie on it? Yeah. What kind of questions? I'm not sure if I have time for questions because I know there are other people who will be speaking, but you're also most welcome to call me. I'd be happy to talk with you about this.
Dr. Lindauer, there is a question in the chat about having a person to care for in the home. Can you tell us a little bit about that? There are many of us that are on the call that are distance caregivers.
Yeah, thank you. Thank you. So one of the things we've learned over the years is that it can be stressful to take care of somebody with dementia, no matter where that person lives. So to be in our study, you don't have to live with that person with dementia. If that person lives, for example, in assisted care or in skilled nursing or with another family member, all we ask is that you provide about 4 hours of care per week. And by care, we mean things like perhaps your family member lives in assisted living and you manage the medications and you talk with the nursing staff and you call your mom, 5 days a week and you'll do her laundry. All of those things count as care. So not a lot of care. We do ask, strangely enough, that if you're in our study, that you do have things you need to talk about, things you need to work through. If things are going really well for you, you're not feeling any stress or burden, this isn't the study for you. And that's wonderful, but we're here for people who are struggling.
Will you repeat Winnie's telephone number and email address?
Yeah, so Winnie is at 404-712-9823. And I can put this in the chat box as well, but it's Winnie, winnie.n.jacobs, Jacobs at Emory.edu. And I'll put that contact information as well as the direct line to our team in Oregon. You can ask any of us, we're happy to help. Thank you, Connie.
Okay, and I guess just to, again, I guess there may be some discrepancy about the primary caregiver in the home. A or B? They need to have a primary caregiver in the home, or B, they don't?
So the person with dementia does not have to live with the main person that identifies as the care partner. The care partner does need to be a family member, and you do need to feel that responsibility as a caregiver to your family member. So if you are perhaps not the main person kind of overseeing care, that wouldn't be a good fit. But if you're the person that is responsible for making sure your mom, your dad, your sister, your brother is getting the care you need, where they need wherever they are, then they're most welcome to call us.
And just to kind of help Dr. Lindauer and Dr. Wharton a little bit better, I'm looking at some of the questions in the chat, just because I've said this before. If you are a family member who has somebody in your family who has a dementing disorder, whether you're the person who's directly responsible for taking care of that person, or you're the person who assists that person from a distance, please make an effort to get involved in some kind of education about caregiving, and certainly about the disease process that you're experiencing. I appreciate that many of the people who are participating in our conference today may be caregivers, not so much just for somebody who has dementia, but somebody who has something like cancer or some other chronic disease process. At the end of the day, being a caregiver, regardless of what the disease entity is, can be very stressful and can be very overwhelming. But more importantly, if you become a trained caregiver, you learn more about the disease process and what's expected. You'll learn that sometimes when we feel a little indignant, little antagonistic toward the person we're caring for, that's not really a bad thing. That's kind of like a normal reaction. But the more you learn about how to deal with family members in a training class, that's going to help you in the long run. So I was looking at the chat where there's somebody who said, what about disagreements between people who are taking care of people and people outside of the home? Everybody's situation is a little bit different, but if you're a concerned and dedicated family member, please take the time to participate in some training for your specific disease entity. And again, everybody's a caregiver, but not necessarily of somebody with dementia, so that you learn more and more about how to navigate some of these interesting relationships. Things do change a little bit.
What if the loved one has not been officially diagnosed?
Well, that is my area of expertise, and officially being diagnosed means you have to work in concert with your medical provider, first your primary care provider, to make sure that the things that you are observing are not related to a correctable or treatable medical problem or medication error. And after you do that, if the doctor says this and this are all fine, we need to send you to a neurologist and get more specialized evaluation, then that's what you do. You're not helping yourself, you're not helping your loved one if you don't take the time to make sure that you have the proper diagnosis for your relative.
So Dr. Lindauer, can they participate if they haven't been officially diagnosed?
They do need a diagnosis, yes, that's part of getting into the study.
Okay, and then is this only if that person has stress or fears related to, is it dementia only, or can it be related to COVID or protocol or other outliers?
Yeah, so this study is for family caregivers who care for a family member with dementia, and the caregiver needs to express talk about that care experience and something that the person with dementia is doing to be disruptive to the family. So talking, for example, about COVID, while a very important issue, wouldn't necessarily align with the study unless it's affecting your care and your stress around that care. We have a list of issues that we talk through, and we can certainly talk through those with you.
And this is any dementia?
The ones that work the best are Alzheimer's disease and related dementias. So Alzheimer's disease, vascular dementia, Lewy body dementia. Families who live with early stage dementia, such as frontal temporal dementia, that doesn't fit quite as well because that experience is quite different from those who live with Alzheimer's disease.
Okay. And go
Let
ahead,
me
Dr.
ask one
Parker.
question. Dr. Lindauer, there is a question in the chat. We had Dr. Kenneth Hepburn has a program called Savvy Caregiver, which is a specific caregiving skills training kind of study. Can you kind of tell people the difference between that and what you're proposing to do?
Yes, certainly. So Dr. Hepburn has a wonderful program called Tell Us Savvy. And actually, I was part of that study, and Dr. Hepburn has been a mentor to me. And what Telestella does is really focus on behavioral symptoms. So Tell Us Savvy might be a wonderful program. There are components of that program that do talk about behaviors, but there are also components of Tell Us Savvy that talk about, kind of the basics of caregiving, and gives you a really nice, well-rounded introduction, or if you need just more support. Tell Us Savvy also is group-based. Tell Us Stella is designed really for the later stages of dementia. We're having more of what we call behavioral symptoms, things like wandering, refusing to brush their teeth, hitting, aggression, refusing to eat. The issues that we deal with are the ones that you bring to the table, but we also know some of those. So those are some of the common issues. Also in Tell Us Stella, we meet one-to-one with you for 4 weeks. So you get some really personalized attention for an hour a week for 4 weeks. Some families come to the study with behaviors that are really upsetting, that they're not real comfortable sharing in a group setting. So we introduced the idea before we put you in a small group.
So again, just for people who aren't really clear, Dr. Lindauer is talking about a way to support caregivers of persons who have, let's say, advanced dementia, such that they're exhibiting some behaviors that are very frustrating and annoying. Wandering, not sleeping late at night, not cooperating with bathing, grooming, and things like that. That's a little different from the Savvy Caregiver Training Program. So there are different things that are being offered. Dr. Lindauer is specifically wanting to help caregivers deal with people who have, for lack of a better expression, annoying behaviors that can be very disruptive to the home. Correct, Dr. Lindauer?
You nailed it. Thank you so much.
Okay, and Dr. Hepburn's Savvy Caregiver Program is really training you about how to be a better caregiver and how to, let's say, develop a network that helps you to take care of this person. Dr. Lindauer's program is not doing that. It says, can we have Dr. Lindauer's email? I think Dr. Lindauer has put her information in the chat, but I feel it's very important. I see lots of very personal, individual experiences that are being discussed in the chat. And this is just, these webinars are to help you get information and to help you deal with what you're dealing with. Everybody's situation is different. We would really strongly advise you to discuss some of your very specific concerns with your primary care doctor and your family's neurologist so that you can get the right kind of attention. Okay, Dr. Lindauer in Oregon can't help you in Georgia, can't help you in Alabama with specific things. Please engage the services of your primary physician and or neurologist or psychiatrist if that's who you're working with. Okay,
Dr. Lindauer, will you, again, Whitney is here in Georgia, but she is the point of contact for both of these studies. It is 404-712-9823. I want you all to write that number down. Call Winnie immediately. Dr. Parker, come back on, please. So just to add context, because we do have faculty here that they are experts, and in a general and generic way, the stigma around getting diagnosed is one thing, but trying to get a diagnosis is another hurdle. How can a care partner navigate that landscape when they know that their loved one needs to get a diagnosis, but it's an uphill battle, especially with, we don't have adequate specialists as it relates to cognitive neurologists. So I know that viewers are tuning in and they just want a little bit more guidance from
Okay.
Dr.
All
Wharton,
right.
Dr. Parker, Dr. Lindauer, please.
So.
Yeah, and you can stop sharing, Cornelia. Thank you. Got it. Perfect.
So for the average person who has somebody who has a dementing disorder, let's just say you say, okay, they're confused and we think it's Alzheimer's, we think it's senility. How do you go about getting that evaluated? Again, start with your primary care provider, because some of these behaviors, some of the things that you're observing may be related to a treatable condition. In consultation with your primary care doctor, you can evaluate for those things. And it's very important for you to make sure that those things that are treatable, such as an infection, such as uncontrolled diabetes or hypertension, those are risk factors for things that need to be managed. You cannot send somebody with unmanaged chronic disease to a neurologist because they'll say, I don't know what this is because this person's undergoing active chemotherapy. Let me see them when they finish the chemo. Then I can make it a better assessment. It's important for you to see the primary care doctor first. And when you see that primary care doctor can refer you to the appropriate subspecialist. Maybe that specialist is a neurologist. Maybe that specialist is a cardiologist, because what you're seeing is an undiagnosed irregular heartbeat that's causing little microemboli and little mini strokes. So it depends. So you need a full evaluation and diagnostic evaluation by your primary care doctor, who can then refer you to the appropriate neurologic specialist and order different tests. We have had Dr. Felicia Goldstein on, who's a neuropsychologist. She does specific testing, neuropsychologic testing, to kind of see how your brain works and how your brain functions. But Dr. Goldstein is not a medical doctor. She's a clinical psychologist, and she does kind of like learning abilities, things like that. All of that is part of an evaluation for somebody with a dementia. So here in the Department of Cognitive Neurology, you can schedule an appointment with a neuropsychologist who can do cognitive testing and tell you what the deficits and how your brain functions are. Like, are you having processing problems? Are you having language problems? Are you having memory problems? They can pinpoint and tell you what those things are. So together with your primary care doctor, who has eliminated all treatable medical causes, you can be seen by a neuropsychologist who can do the cognitive testing and training skills test to see where you're having deficits. And this usually helps us sort out sometimes clear depression versus real brain functioning abilities. And then the neurologist comes in. Now, what does a neurologist do that the rest of them don't do? Well, in my practice, I generally order my own MRIs and or PET scans, and I did do my lumbar punctures. But a neurologist will more likely add to what your primary care doctor has done. And traditionally, the way we're diagnosing Alzheimer's in particular here at Emory is we do a lumbar puncture and we get the cerebrospinal fluid and we look for the protein precursors that indicate that you have Alzheimer's or you don't. They're either present or they're not. So that's an essential part of what the neurologist does here. And if you're not in Atlanta and you're not a part of the Emory healthcare system where you would get a referral to our cognitive neurology department, we do have the Georgia Memory Net. But the first place everybody should start, regardless of where you are from, is with your primary care doctor. And if you don't like that one, find another one who can work with you. But no neurologist is going to see you for a diagnostic evaluation without a medical clearance by a primary care or internal medicine doctor. Does that help?
That helps. And so, Dr. Parker, for the 4% who are new, can you just quickly tell them the difference between dementia and Alzheimer's?
Right. Dementia is a broad term for a spectrum of disorders that make it such that an individual doesn't function by him or herself. They don't remember things. Maybe they're not using the right words for the right things. They can't process information anymore. They're speaking half in English and half in Polish, or half in English and half in something else, whatever their original language was. So dementia, there are several different types. Alzheimer's is the most common, followed by a mixed dementia, which can be Alzheimer's and a vascular disease, or Alzheimer's and a Lewy body dementia, frontotemporal dementia. There are dementias that are associated with unmanaged HIV infection. There's a dementia that's associated with chronic alcoholism, alcoholic encephalopathy. There's traumatic brain injury. Those are all types of dementia. And because they're different types of dementia, they have different things that cause them, and ultimately different things that will resolve them. Unfortunately, regardless of the type of dementia you have a part of your brain that no longer works, and there's nothing in medical science to date that's going to restore the function of those cells that are no longer functioning. So you're not resurrecting brain cells and letting them go on. There is no such thing as brain cell resurrection. It doesn't occur. There's nothing you can buy on television, no Prevagen, no oil, no snake oil, nothing that you can buy on the market that they sell anywhere that's going to restore brain cells that no longer function.
Got it. Okay, and so with that, we will close. Thank you, Dr. Lindauer. Thank you, Dr. Wharton. Thank you, Dr. Parker. We are a research center, and until there's a cure, research is our only hope. Are there any final remarks from Dr. Lindauer or Dr. Wharton before we discuss what's next with CEP Live? You're muted.
Thank you for the invitation.
All right. And so,
You're
Dr.
welcome.
Lindauer, we may invite you to come back on and just talk about managing difficult behaviors. I think that, and again, you all, we're just giving you a 50,000 foot view in this 1 hour. Any of these topics we could address all day, or at least for one session. But again, it's to give you exposure, it's to give you an opportunity to be in pursuit of research. As one individual said, they are, as a caregiver, working diligently, looking and seeking out training and sources so that they can be an informed caregiver. So that is our encouragement, and our prompt for you today is seek out credible sources, evidence-based, academic, and credible sources to help you on your journey, whether you are just wanting to age well, you're a caregiver, or what Dr. Law and Dr. Parker refer to as free-range elderly. All right. So with that, I think we are just waiting for Matt to come on and tell us what we can expect for our cognitive empowerment program. And I don't know, Crystal, if you can drop the link to CEP Live. I don't see Matt. I don't see where he has joined us yet. But since January, if you've been joining us since January of 2021, our Emory Cognitive Empowerment Program that we refer to as CEP, they've been hosting virtual sessions immediately following our program at 3 p.m. each Tuesday, right after our program. And it's a different link. So if we're able to grab that link, we will post it in the chat. Otherwise, we will see you back here next Tuesday. Again, we will begin with exercise. That's how we kick off our information sessions. And then we'll be featuring our faculty and staff for 1 hour. And then I think Dr. Parker is finalizing our agenda for our 21st forum that will be virtually in October. So we'll have a big announcement next Tuesday to let you know what that lineup looks like for late October. All right, well, thank you all for joining us, and be sure to check your email because the link for last week's recording with Dr. Law and Dr. Parker is embedded in your email. All right, see you next Tuesday. Goodbye. Oh, hey, Matt, hello. Tell us who's on. There's a couple I think Crystal posted the CEP, but for those that are still hanging out, you want to tell them who's on?
Yeah, sorry I'm late. So today we're gonna be doing yoga with Megan, and so I'm gonna be starting that up in a second. But we were just getting Megan ready. But yeah, if you guys would like to do a yoga workout, come join us. I will post the link in chat for anyone who's still here.
Okay.
And looking forward to seeing everyone.
All right. So yoga with Megan. Head on over there and we'll see you next Tuesday, everybody.
All right, links in chat. Thanks everyone. Bye guys.